Let's start with the prospect study, which you all know. There were 3 predictors of events: a plaque burden more than 70%, a virtual histology thin cap fibroatheroma, and a lumen area less than 4 square millimeters. And if you had all 3 of these, there was an tenfold increase in events. Plaque burden is critically important, as seen in these 2 studies. If the plaque burden is less than 50%, you almost never get events. And a plaque burden of about 70% best separates plaque rupture from no plaque rupture, and a culprit plaque rupture from no culprit plaque rupture. That was supported by the European collaborative project called Atheremo-IVIS. Again, the same 3 predictors of events. And in this particular study, a plaque burden of 70% separated early events from late events. Now, in terms of where the fibrous cap thickness becomes important and rupture prone, this is a study from the Massachusetts General Hospital Core Laboratory, and it pretty much established that a fibrous cap of approximately 70 microns separates a cap that will rupture and not rupture. Why do I mention that? Because in the CLIMA study, which was an LAD survey study done in Italy, they selected a fibrous cap thickness of less than 75 microns, OCT-defined macrophages, a lipid arc more than 180 degrees, and a lumen less than 3.5 square millimeters as criteria for a high-risk plaque. And depending on the number of criteria, you can see the event rates. But in particular, if you have all 4 criteria compared to without all 4 criteria, there's an probably about a 5-fold increased event rate. This is an example. You can see actually 2 examples from CLIMA. You can see that the top example does not have a thin fibrous cap, does not have macrophages, and here you have a thin fibrous cap with macrophages, and you can see that this is relatively stable, and this went on to cause an event. Fast forward to the LRP study, which was a study using near-infrared IVIS, and again, the predictors are similar to prospect. A lipid core burden index more than 400, plaque burden more than 70%, and a lumen area less than 4 square millimeters. And when you compare, and particularly a max LCBI less than 400 compared to more than 400 on a patient level or segment level, you can see the increased event rates 2 to probably 4-fold. Now, Prospect 2 was a NIRS IVIS natural history study, similar to Prospect 1, except there was an embedded randomized trial that I'll get to later. The predictors in Prospect 2 were an LCBI of 325, which was the upper quartile, a plaque burden more than 70%, and we've touched on why this is so important, and a lumen area less than 4 square millimeters. And again, if we look at events, we can see that if you have a plaque burden more than 70%, the event rate is, say, 3 to 4-fold higher on either a patient level or a lesion level event, again substantiating how important is a plaque burden more than 70%. LCBI more than 325, a doubling of the event rate. And if we then break it down to plaque burden 70% and LCBI of 325, and we look at the 4 different possibilities, it's only if you have a plaque burden more than 70% and a max LCBI than over 325 that you have a higher event rate. One or neither of these is not associated with instability. What I really like is this curve. This was done in this supplement to the Lancet paper, and it shows plaque burden and LCBI as continuous variables. And you can see the plaque burden is pretty stable until you hit about 70%, and then there's an exponential impact on events. and the LCBI is about the same, to hit about 400, and then an exponential increase in events. And so when we compare LRP and Prospect 2, you can see how similar are the findings, showing the consistency of NIRS-IVUS in its ability to predict vulnerable plaque events. Now, in Prospect, we looked at diabetic patients, and diabetic patients behave differently from non-diabetic patients, which led to the combined study, which took patients who had an FFR that was non-ischemic, and then shown here, and then divided the patients into those with and without an OCT thin cap fibroathyroma, and followed them for 18 months. And you can see that even in FFR negative lesions, the presence of an OCT TICFA has a 4-fold increase of events during this follow-up period. Now, why did I go through all of this really quickly? I just wanted to show you that we are able to detect thin cap fibroathyromas, which are the precursors of plaque rupture. Whether you use NIRS-IVUS, whether you use OCT, we know what a thin cap fibroathyroma looks like. We know what a plaque that causes events look like. That's no longer debatable. But there are things that are debatable. So number one is that the events related to coronary disease are gradually decreasing on a population basis. And this is from the SAS Institute, which collects data in ways that normal humans cannot. And you can see the trends of cardiovascular mortality for males and females in the United States from 1968 to 2016. So the first thing is our drugs, which is what this really reflects, are doing a good job. The second, and that's supported by comparing Prospect 1 and Prospect 2. So if you look at the MACE rates in Prospect 1 compared to Prospect 2, total MACE has gone from 20% to 13%, non-culprit lesion-related events from 12% to 8%. So we're clearly having a positive impact with our pharmacologic therapy, and we're having an even more positive impact on our lesions because culprit lesion-related events have fallen from 13% to 4%. And the events are really revascularization events. They're not the hard events of death, cardiac arrest, and spontaneous MI. And here we look at Prospect, CLIMA, LRP, and Prospect 2, and just look at death from cardiac causes. It's almost zero during the follow-up period. Cardiac arrest, almost zero. MI, maybe 1%. So we're not preventing, we wouldn't prevent death MI, we would be preventing repeat revascularization for unstable symptoms. Secondly, if we were to take a patient to the cath lab and go looking for vulnerable plaques, we're going to miss half of them. So these are the three studies, Prospect, LRP, and Prospect 2. And if you look at how often does baseline imaging identify the lesions responsible for non-culprit events, it's 50%. We miss half of them. Whether they are in a branch, whether they're too distal, whether it was too hard to image them, we miss half of the vulnerable plaques. There are complications. Prospect 1, it was 1.5%. It's dropped in LRP and Prospect 2, but the complication rate is not zero. And head-to-head comparison among different technologies have shown a disagreement of about 25 to 30% among the modalities as to whether an individual plaque is or is not a TICFA, and even within a modality, in this case, comparing three core laboratories, the agreement in terms of lipidic plaque is only about 75% by OCT. Okay, so well, maybe it's just a technology. Well, we asked this is an old slide from Paulina Margolis, who was involved with volcano and virtual histology, and she asked 4 pathologists to look at to look at 2 specimens and decide whether or not these are vulnerable plaques. And you compare these 4 pathologists, and you can see that they come up with a very different interpretation as to whether the lesions are or are not high risk. And then finally, the majority of thin cap fibroatheromas either heal, develop a thicker fibrous cap, remain stable, or rupture silently, leading to disease progression and a larger plaque burden rather than to an actual acute event. So for example, in this elegant study from Renu Vermani's group now 20 years ago, there were 142 men died suddenly. They had 475 healed plaque ruptures that happened asymptomatically, but only 44 acute plaque ruptures. So if you do the math, 90% of plaque ruptures rupture asymptomatically. And in terms of serial imaging studies, you can see that in this combination of these 4 studies, if you have 100 TICVAs at baseline, 60 heal, 40 persist, but there are about 50 new ones. When does a rupture plaque produce an event? If there's a small lumen area because of a combination of a large plaque burden and a thrombus. And in terms of secondary plaque ruptures, they remain stable and contribute to disease progression. So we know that plaque ruptures are the most common cause of events, but we also have erosions and calcified nodules. And there is no data whatsoever on the precursors of erosions or calcified nodules, which are half of the acute culprit lesions. So for example, in this study from, a sub-study from CLIMA, looking at calcified nodules, there are stable calcified nodules, there are eruptive calcified nodules, and these have a worse long-term prognosis. What about therapy? I shared with you the fact that Prospect Absorb had an embedded sub-study, and it's widely reported as being positive because lumen area was larger at follow-up in the Absorb group than the guideline-directed medical therapy group. But the truth is, there was no late lumen loss in either group. The CFD curves show that whatever lumen area was achieved at the end of the procedure, whether using a scaffold or using guideline-directed optimal medical therapy, stabilized the lesion. And that was substantiated in this review article by Nichols, showing that a reduction in LDL is related to an annualized increase in fibrous cap thickness or increased stability. And PCSK9s have been shown to reduce lipids significantly. Here you see baseline, a large lipidic plaque on near-infrared spectroscopy that almost disappears after PCSK9 therapy. So will it ever make clinical sense to search for, diagnose, and treat vulnerable plaques? And the answer is, I don't know. We know we can identify a TICVA, which is a precursor of plaque rupture, but they account for only 50% of lesions that cause acute events. High-risk precursors of other plaques, erosions and calcified nodules, have yet to be identified. Multi-vessel intravascular imaging identifies only 50% of lesions that cause future events. Most, perhaps 90% of TICVAs develop, stabilize, heal, or rupture asymptomatically and don't cause events. And with modern medical therapy, fibrous cap thickness increases and heart events, death and MI that are related to plaque rupture occur only 1% per year. So yes, we can detect vulnerable plaques, but I'm not sure that it's worth the hunt, and I certainly don't know whether we should be treating them. Thank you for your attention.